Good afternoon, everybody. My name's Claire Coughlin. I'm the clinical lead for Bowel Cancer UK, and I'm delighted to welcome you all here this afternoon for our education session on exploring the symptoms and treatments of anal cancer and the latest research in this field. We've got a fantastic speaker for you this afternoon, and I'm really delighted that we're able to bring this session. Lots of you have asked us for this, and I know from experience that whether you work at the diagnostic end of the pathway or whether you're referring patients onward or supporting patients in follow-up, this is something we always want more information about. So I know this is going to be a great session this afternoon. So now I'd like to introduce our fantastic speaker for this afternoon, Noreen Chindawi. So I'm very grateful to Noreen for speaking for us this afternoon. She's a nurse, anoscopist and anal cancer CNS at the Homerton Foundation Trust in London. She works in the anogenital neoplasia service, and she's worked in the trust for the past 21 years. She's there now on screen. Great. Hi, Noreen. She's got an extensive background in surgical nursing. And in the anogenital neoplasia service, she supports people diagnosed with anal cancer before, during, and after their treatment. As a high-resolution anoscopist, she's part of the hand screening and treatment service for people who are at risk or have developed anogenital precancerous lesions. Noreen also runs post-anal cancer clinics and trains nurses across the country to support and develop HRA local services, as well as trains anoscopists. So thank you so much, Noreen. I'll hand over to you now and I'll sit back and enjoy your session. So thank you.
Thank you, Claire. Just a minute. Okay, thank you, everybody. Thank you, Beth. Thank you, Claire. Thank you, Laura. And hello, everyone. Today, I'm going to give a talk on exploring the symptoms and treatments of anal cancer and the latest research in this field. So our learning outcomes today, we're just going to give an overview of anal cancer, look at the epidemiology, the risk factors, the symptoms, the current management. I will not touch much on screening, but maybe a little bit on AIN and then a bit of research. Okay, so the first thing that we need to do is there is a diagram there of the anus, and it's just to give us an idea of the organ that we are looking at. And usually you find that with the anus, it's only when we have problems in the anus, that's when people realize how much of a problem it can be. But otherwise, under normal circumstances, I think it's a very forgotten organ. So the anus is about 4 to 5 centimeters long, and it stretches from the anorectal junction to the anal margin. So there are a few structures there that we may just need to mention, which makes the anus a very important organ. We have the external and internal sphincters, of which, if they are damaged, you find that we have quite a problem with fecal incontinence. And then we have the dentate line inside there. The dentate line also is very important because it's just sitting about 1 centimeter from the anorectal junction, or we call it the squamocolumnar junction. So above the anorectal junction there's the columnar tissue, and all the way down, coming down the anus, we have the squamous cells, of which most of the times that's where most of the anal cancers are found. So the dentate line, why I said it is important for us to know about it. Above it, when the cancers develop in that area, they kind of drain into certain lymph nodes. And then if cancers happen below the dentate line, they'll also tend to drain to certain lymph nodes underneath, in the pelvis. So we have the anal verge, and then we have the anal margin. The anal margin is 5 centimeters. It stretches 5 centimeters distally from the anal verge. So this is all the area which is covered with the lines. So inside the anus, we have the crypts, we have anal glands, we have many other structures there inside. So it all depends. We have hemorrhoids and so forth. So depending on what's happening to us, we really need to know a little bit of anatomy of the anus. All right. And my next slide is pelvic lymph nodes. Pelvic lymph nodes are it's really important for us to know our pelvic lymph nodes, because with anal cancer, if it spreads, it goes to the lymph nodes. And we've got the inguinal lymph nodes in red. We've got the mesorectal lymph nodes. We've got the obturator, internal iliac ones, the green ones, and then we have the external iliac, those ones in red, and then the rectalis superior, inferior mesenteric, and common iliac nodes. So when we are staging anal cancer, we remember we have our TNM staging and the nodal staging. These are the lymph nodes that we are looking at. So it is very important for us to know something about them. And then briefly, I'll just go through the hierarchy of anal cancer. So most of you most probably are aware that anal cancer has a precancerous stage. It's got a precursor stage, and this starts off as low grade. And the precursor stage is known as anal intraepithelial neoplasia. So it's graded from 1 to 3. And AIN1 is low grade, AIN2 to 3, depending on the P16 biomarker, especially for the AIN2, we can push it up to be high grade or down to be low grade. So we have high grade AIN there. We go on to cancer diagnosis, chemoradiation therapy treatments, or salvage surgery, formation of stoma, and eventually death. This is just a hierarchy of where anal cancer comes from and where we end. Right. So the epidemiology for anal cancer. Anal cancer itself, what is it? Anal cancer is the cancer of the skin lining the anus, and the epidemiology stands at less than 1% of all cancers. It is a very rare cancer, and less than 3% of all gastrointestinal tumors. And the most common histological subtype is the squamous cell carcinoma, with an incidence of 0.5 to 2 per 100,000. But of late, throughout the world, we have noted a rise in the incidence of anal cancer, and this is the reason why it's generating a little bit of more interest. How do we classify anal tumors? We've got 85 to 90% being squamous cell carcinoma of the anus. And then we do have rare cancers as well inside the anus that can develop. We've got the adenocarcinoma of the anus, which can develop from glands. And also, we can find adenocarcinomas at the squamous-columnar junction or the anorectal junction, where it meets the cells from the rectum. And usually adenocarcinomas develop from glands of the anus. We have melanoma of the anal canal, basal cell, which affects mostly cells outside and on the perianus, and that is within that 5-centimeter radius of the anal orifice, affecting the perianal skin. And then other rare types include cloacogenic tumors, poorly differentiated neuroendocrine tumors, and lymphomas. But they are rare. As we said, 85 to 90% are squamous cell carcinoma of the anus. What are the causes of anal cancer? So the causes of anal cancer, like I said, most of the cancers are, the 85 to 90% is usually squamous cell carcinomas. And in these squamous cell carcinomas, in the histological findings, you'll find that most of the anal SCCs, there is HPV attributed to these tumors. So even though the cause of anal cancer is not fully understood, but we do have HPV, which seems to be the main cause of anal cancer. How do we contract HPV? HPV is a very common sexually transmitted disease. How do we get it? Skin-to-skin contact of the genital areas, through oral sex, through sharing of sex toys. And the human papillomavirus. Here's just a few facts of the human papillomavirus, which is the main cause of anal cancers. So they say at the age of 44, if you've had one sexual partner, you have a 49% chance that you've picked up HPV. And 90% of the general population are seropositive for HPV, so it is highly prevalent. For men who have sex with men, 65% of them have HPV in the anal canal. And if it's men who have sex with men and are living with HIV, 75% of them have high-risk HPV in the anal canal. If it's women who have cervical intraepithelial neoplasias, 45% of them have high-risk HPV in the anal canal. So you can see how much people are exposed to HPV and the likelihood of maybe developing an anal cancer at some point in life. The main thing that we do stress is you don't have to have anal sex for you to have HPV in the anal canal. It can be self-inoculation through wiping. When we speak to patients, they find this very, very distressing because it's like a stigma that has been placed on anal cancer, because the minute people start talking about anal cancer, people think you've had anal sex or you've been promiscuous or things like that. Some of my patients, they do tell me that it is very distressing and it can really place a stigma on anal cancer patients. There are some risk factors that are associated with contracting HPV and a high risk for developing anal cancer. Certain sexual practices, receptive anal sex, cigarette smoking, weakened immune system. So we are talking of long-term steroid use or immune suppression, for example, for patients who have received solid organ transplants, autoimmune disorders like systemic lupus, erythematosus, the human immune deficiency virus, HIV. Patients are really at risk of developing anal cancer. History of anal dysplasias, cervical vulval dysplasia, and lower genital malignancies. If you've had a history of HPV, history of other HPV-related cancers, even a history of low risk HPV strains, things like warts, you can also be predisposed to anal cancers, because if warts are there for a very long time, God knows what is brewing underneath them. So we just need to be careful with those as well. And anyone whose age is above 75, for some authors, they actually put it down to something like 65. So those are the risk factors to anal cancer. What are the signs and symptoms of anal cancer? The signs and symptoms of anal cancer appear gradually and they are often mistaken for less serious conditions. So, and very early cancers, usually there is no symptoms at all. So the early stages of anal cancer, patients can present with bleeding during bowel movements, or sometimes even without opening your bowels, they may see just blood coming out, persistent discomfort or mild pain in the anus, a discharge of mucus, perianal skin lesions, itching of the perianal skin or anal verge, unusual lumps or growths around the perianus and the anal verge. Those are some of the early stage symptoms. And then as the tumor grows bigger, sometimes patients would present with persisting non-healing anal ulcers. And usually if a patient is presenting with the precursor changes or precancerous changes of anal cancer, the high-grade squamous intraepithelial lesions, you find that patient may have ulcerations, and all round there's changes that indicate that it's an anal, it's HSIL. If you take a biopsy from that ulcer, most probably it will come as anal cancer. Difficulty controlling bowel movements like fecal incontinence, pelvic or perineal sepsis with or without fistula formation. So sometimes patients will just start off with a little fistula, and this fistula sometimes you may not even think that it's related to anal cancer, but there are some malignant fistulas that will end up being anal cancers. So if not seen, they may end up with sepsis, and that's the only time you can realize that this patient has developed a tumor. And usually with such tumors is when the tumor is already advanced. Swollen inguinal lymph nodes, persistent and significant pain in the anal or rectal region, large and noticeable lumps or masses around the anus, a sensation of fullness or blockage in the rectum. So I'll go back to swollen inguinal lymph nodes. It is very important when managing patients with swollen inguinal lymph nodes, because it's one of the anal cancer symptoms that can be very hideous. Usually a patient will present with swollen inguinal lymph nodes, but there's no other sign or symptom that will be there from the anus. So patient, most probably initially they are taken round to hematology, they get investigated. From there, most probably they will go then to the colorectal team who will do all the investigations until somebody most probably decides, why don't we do a fine needle aspiration? And sometimes patients are even taken to sexual health because there are conditions like lymphogranuloma venereum. They also present like swollen inguinal lymph nodes. So these are some of the complexities that comes about when we are looking at anal cancer. It can be very difficult to diagnose. Patients go round and round, going to different teams before they're actually confirmed in anal cancer. All right, diagnosis. So like I said, anal cancer can be hard to diagnose. And the reason why anal cancer is hard to diagnose it is because most of its signs and symptoms, it presents like any other benign condition in the anus. For example, we do get a lot of bleeding with hemorrhoids, isn't it? We do also get a lot of pain with fissures. And even with fissures as well, we can also get a lot of bleeding. So I have had a patient who went to her GP for almost 1.5 years, and they were being treated for hemorrhoids. They had pain in the anus, they were bleeding until this patient could not sit. They were literally not able to sit. This is when they decided, okay, go to the hospital. They went through an EUA. Luckily, they met a doctor who just wanted to find out exactly what was causing this severe pain. Otherwise, most probably, they would have been sent home again with rectogesics and analgesia and more laxatives until the tumor really grows big. So it is important that we focus on some of these signs and symptoms which mimic other conditions as well. So what do we need to do when we are diagnosing anal cancer? You need a detailed medical history. So remember, there are so many things that you can, differential diagnosis that you can have in the anus, things like tags, maybe benign lumps, any other anal lumps that you can find, there piles, there's warts, you can meet giant condylomas, verrucas, all these you need to exclude and make sure that it is not a cancer. So you have to do what you have to do. And then we go on to physical examination. Your physical examination, of course, it's you look and see what sort of lesion you're dealing with around the anus. Because, I mean, if you look at a lesion, there are some lesions that automatically, when you look at them, they don't look right. So sometimes the best thing to do is biopsy, and at least you know what you're dealing with. And then we have digital anal rectal examinations. And this procedure this tool, it's a very, it's one of the tools that we can use to diagnose cancer. And it's the safest and easiest one, where you have to do even when you're screening your patients, where you just push in your finger, your finger, and where anal cancer feels like grains of rice or little buttons inside there. We do have high resolution anoscopy, which is an examination where you go inside the anus with a proctoscope, paint with acetic acid, and then you take biopsies in the areas that you think could be high grade or areas that are suspicious of anal cancer. Or a patient can be sent to theaters for an examination under anesthetic, and biopsies are done. So I've got a few images there of anal cancers, presentations of anal cancer. We have that top one there. It's an anal cancer, most probably, that is stretching from inside the anus all the way outside, and that's how it looks. And then this other second one, it's a perianal tumor as well. The other one on the right top, it's an anal cancer, most probably on a background of a high-grade intraepithelial neoplasia. So when you go inside there with a proctoscope and then you paint with acetic acid, you see those dense white tissue that comes out. Within that tissue, there are also other indicators that you may see. And if you take a biopsy, that's how we diagnose anal cancer sometimes. And then the image at the bottom there is this is an advanced anal cancer. So these are some of the images of anal cancers that I had. So besides your thorough medical history and physical examination, we go on to radiological investigations. Radiological investigations, you need an MRI, MRI with anal sequences, or the one that picks on diffusion weighted imaging. Otherwise, if you send patients just for a rectal MRI scan, if they are small cancers, you won't be able to pick up small cancers with a rectal MRI or a perianal MRI, or even the MRIs that are done for fistulas and so forth. We are not able to pick up early cancers with that. So you need an MRI with the right anal sequences. So if you ask your radiology teams, they will be able to tell you, just specify it, or when you request your MRI, so that at least you'll be able to pick up all the areas or the right planes and sequences that are required to diagnose an anal cancer. And then you have CT cap, chest, abdomen, and pelvis. It also helps us in the staging of anal cancer and to see if there's any spread. And then the PET CT. PET CT, we do include it. We think it is very important in the staging of anal cancer, but according to the ESMO guidelines, they think sometimes it's not one of the mandatory ones that we have to do. We rely mainly on the MRI and CT cap. But in our MDT, we use PET CT quite a lot because it helps us in staging of anal cancers. Because sometimes with MRI, if suppose there is a lymph node that has been missed, you find that it lights up on the PET scan, and we are able to proceed that way and investigate more to find out what's happening with that particular lymph node. Of course, some of them may be just reactions or whatever, but it does help. Better to know something that's happening than to leave it out. And then we have things like endoanal ultrasound scan. This is also something that comes off PET CTs. So if something has been noted on a PET CT or even on an MRI scan, and we can't really tell what's going on, whether and this most probably half the time, sorry, it's patients that we are investigating for anal cancer. We are so sure that it's an anal cancer, but we are not getting a histological finding, because for us to confirm that it's an anal cancer, the histology have to say that it is. So sometimes we are not finding, we are just finding high grade, but the MRI scan half of the time is telling us it looks like a T2 tumor, it looks like a T1 tumor, but we are not finding it. So sometimes if it is a patient who is very difficult to diagnose, we have to send them to endoscopy. They go for an endoanal ultrasound scan, and they'll have their aspirations. And sometimes they do confirm that patients have anal cancer, and treatments will start from that end. And then we have fine needle aspirations of the lymph nodes. For example, patients who present with just swelling of the inguinal lymph node, then final needle aspirations are done to confirm the diagnosis, or even those that have been confirmed as well, just to make sure that the swollen lymph node, it is really a cancer in view of treatment that needs to be done. We also send them for fine needle aspiration. We do ask our patients, I think for us it's mandatory for HIV blood, because sometimes with anal cancer, we've noted that it's 80 to 95% of the anal cancers are caused by HPV. So if you are immunosuppressed, then your immune system is not able to clear HPV properly. So if a patient is HIV positive, we want them to be started on treatment. If they come out positive, to be commenced on treatment. Their CD4 improves, their viral load gets better, becomes undetectable, and that way you are able maybe to control. The immune system is able to control HPV, and we are able to manage patients in a better way. And HPV assessment and P16. Sometimes histologically, tumors, these anal tumors, they are assessed for HPV and for P16. So if this tumor is caused by HPV, a P16 biomarker is also checked. So if the P16 biomarker is diffuse, is really infiltrated the tumor, they actually say it helps in chemoradiation therapy. They say tumors with a P16 positive, they respond very well to chemoradiation therapy. So we do check for that sometimes, but otherwise, even if it's not checked, patients still go through CRT anyway. So just a brief diagram of a digital rectal examination there. So we are saying as we do our examinations, we really dare to dare. So we do cover the rectum, the anal canal, and like I said, this is a very important part of physical examination. We are able to detect cancers as we do a digital rectal examination just through feel, through touching, and as you are swiping those gentle lateral pressures, you can feel quite a lot of stuff when you are doing that, because you are able to tell of the contour of the lesion. You are able to tell most probably the shape. You are able to tell where you are feeling the lesion. You are able to tell the size of the lesion, and you are able to tell whether the lesion is superficial or the lesion is submucosal. You are also able to tell if it's just a groove, if it's a fissure, or if it's a fistula. You are able to feel and tell a lot of stuff from just a digital anal rectal examination, which makes it very important in diagnosing early cancers. But I think it's a skill that you have to master, and it can be learned. High resolution endoscopy. I'm not going to say much about high resolution endoscopy, but we are saying it's the gold standard for diagnosis, and the Americans depend on it. And I think the rest of Europe is just taking on it as well. It's amazing that in the UK, a lot of us are now doing high resolution endoscopy, and I'm glad there are so many nurses that are interested in high resolution endoscopy, because it's a skill that all of us can do, and we can help diagnose very early cancers and prevent the complications that come in when cancers are left to go into their advanced stage. So this, like I said, it's a procedure that allows for examination of the anal canal and surrounding skin using a colposcope. So we are using a colposcope with a magnification of times 30. So you are able to see quite a lot of changes inside the anal canal and on the perianus as well. So the procedure is used to check for abnormal cells that have a higher likelihood of turning into cancer. And it also allows us to be able to visualize target areas and then biopsy them. And if we have to treat these precancerous changes, then we go on to ablate them with high fricator or with a diode laser machine, whichever way, or carbon dioxide lasers. So whichever way you'll be treating the precancerous changes, at least it does help us prevent anal cancer. So I would say in the UK at the moment, we do not have a screening program as yet, but something is on the way, because with, I think, the British HIV Association, they are going to take on anal cancer screening to the high risk groups because of the risk that we have with HIV patients. So there's going to be a draft of that in our BIVA guidelines, and we are going to see most probably a lot of training that is going to go on, most probably with you colorectal nurses, with HIV nurses, with health advisors. A lot of staff are going to be involved in this because just like cervical cancer, I think anal cancer also need a bit of attention so that patients do not die with something that we can prevent to a certain extent. Right. So we go on to the staging of anal cancer. The staging, like any other staging, we use the TNM staging. And what I have is the 8th edition of the TNM staging. So with our staging, I know there's a newer edition that has come out, but in our MDT, we are still using the 8th edition, which I comfortably brought here to discuss with you. So with the with the tumor size, so TIS is the carcinoma in situ. So carcinoma in situ is not a cancer. It's a high-grade intraepithelial neoplasia, which is AIN3 or HCL. That's carcinoma in situ. Because I know some pathologists bring out results as carcinoma in situ, and everybody worries that patient has a cancer. But TIS, no, it's not a cancer. And then we have T1 tumors, it's tumors that are less than 2 centimeters, T2 tumors between 2 centimeters and less than 5 centimeters in their greatest dimension. The T3 tumors are more than 5 centimeters in their greatest dimension. T4 tumors, it's a tumor of any size invading adjacent organs. For example, a tumor that is invading the prostate, a tumor that is invading the vaginal wall, or fistulating to the vaginal wall. So no matter what size it is a T4 tumor. And then when we come to the nodal stage, NX, it means regional lymph nodes cannot be assessed. Regional lymph nodes cannot be assessed for whatever reason. Patient cannot withstand going into an MRI scan. A patient has metals in their body, so they can't go through an MRI scan, so nodes cannot be assessed. The N0 stage, no regional lymph nodes metastasis. N1, it's metastasis in regional lymph nodes. N1A, it's metastasis in inguinal, mesorectal, or internal iliac lymph nodes. Any one of those or a combination of all of them, that's N1A. So that's why when we looked at that diagram of the lymph nodes, I said they are very important in the staging of anal cancers. So N1B, metastasis in external iliac lymph nodes. So that's N1B. N1C, it's now a combination of 1A and 1B, which is metastasis in external iliac, and N1A nodes in inguinal, mesorectal, and/or internal iliac lymph nodes. Distant metastasis for the MX, metastasis cannot be assessed for whatever reason, like I mentioned on the nodal staging. And MO, no distant metastasis. M1, distant metastasis has been found. Right. So it's the staging of anal cancer, it's very important to have a staging. And oncologists, surgeons, and everybody, they really need to know the staging of anal cancer before it goes on for treatment. Because if a patient goes for treatment without knowing the stage, the oncologist will not know what treatment to really give, because radiotherapy all depends on the size or the stage of the tumor. So my question now to the audience is, when do you think a colostomy is indicated in anal cancer management?
Hopefully you can all see where the chat is and you can type your answers in the chat. Yeah, fabulous. Okay, I don't know if you can see those coming through, Noreen, but so we've got when they're incontinent, when it's causing pain, or bowel obstruction, pain, incontinence, post-surgery,
Yeah,
obstruction.
yeah.
When symptomatic, at any point of diagnosis, loss of bowel movement, poor function. Yeah,
Poor function is
yeah, and
extreme
pain is
discomfort
coming through.
and
Yeah.
pain. Yeah, we all very right. So a colostomy indicated in anal cancer management, locally advanced cancers, they always recommend for a stoma, anorectal pain, fecal incontinence, rectovaginal fistulas, large bowel obstruction. Large bowel obstruction is very rare in anal cancer, but it can happen, but it's very rare. It's very common, most probably in the cancers that are higher up in the rectum at the anorectal junction. So if the cancer grows bigger, then up there it can, but they do happen all the same. And also, stomas can also be performed when there's predicted chemoradiation therapy side effects, which are going to interfere with the patient's quality of life. So they can actually indicate a patient to have a stoma because they've foreseen that patient will suffer during their treatment. All right, thank you so much, everyone, for those answers. So there we go. Stomas, like I said, they are rarely required in patients with tumors of less than 5 centimeters, but above 5 centimeters. And the necessity increases exponentially with size and presenting symptoms. So if at all a colostomy or a stoma can be avoided in anal cancer, it should be avoided, because half the time, once a stoma has been performed, reversing it can be very difficult, because with anal cancer, depending on your staging of your anal cancer and the treatment that you're going to receive, if it's treatment that is going to end up with severe side effects, you are going to end up with fecal incontinence, you are going to end up with maybe a lot of pain in the anus or severe proctitis or whatever, then I don't think the doctors would really want to reverse that stoma, because there are other problems that have been caused by treatment, and eventually the stoma will be the best thing for you. But having said that, I know you've all met patients who've had stomas, and they do not like stomas because it interferes with their quality of life. Everyone who's had a stoma pre-treatment, by the time they finish treatment, the first question is, when is my stoma going to be reversed? And they will continually say that. So anyway, I know oncologists, they're very, very good. They do explain clearly to patients that before their treatment, the stoma can either be reversed, or they may not be able to reverse the stoma. Right. Let's go to treatment for anal cancer. So treatment for anal cancer, it depends on the stage of the anal cancer, like I said before, the location of the tumor. Is it a recurrence? They also look at the patient's age and general health. So these are some of the things that the oncologists look at before they give treatment. So when I say the location of the tumor, we've got anal canal tumors. We've got anal vag tumors. We have perianal tumors. It is very important for us to know that. And we also need to know to look at the patient's age and their general health. Some patients come in with a lot of comorbidities that hinders them going through, or they may not be able to go through CRT because they have all those other things with them. So the types of treatments that we have in anal cancer, we have surgery, which can be wide excisions for small anal margin and perianal tumors. And in this one, we are aiming to have a clearance margin of more than 1 millimeter. And when we have chemotherapy, we have radiotherapy, and then we have the combination of chemoradiation therapy. But CRT, which is chemoradiation therapy, is the type of treatment that basically is given to most patients. Chemotherapy only, I've seen it being given to patients who have received treatment before, and maybe they've had a recurrence of anal cancer. Radiotherapy is some patients, maybe due to age, they can't withstand chemotherapy, so they'll end up having radiotherapy only, or maybe very small tumors that will only need to be cleared with radiotherapy. And then we have targeted immunotherapy. Immunotherapy, to be honest, I haven't really come across a patient who's having immunotherapy, because I'm not working in an oncology center where most of the treatments happen, but it is there. For advanced anal tumors, some patients are being managed on biologics to manage their tumors. And obviously these patients, they've already gone through most probably CRT already, and now they go on to have targeted immunotherapy. But like I said, I've not really seen a patient with who has had that treatment so far. So the gold standard treatment for anal squamous cell carcinoma is chemoradiation therapy. And so the standard treatment for anal cancer is the NIGRO protocol, chemoradiation, on a regime set out in Act 2 of 2013. I'm sure we all know where the NIGRO the Nigro protocol came from. It was from Dr. Nigro, who developed this treatment in the 70s. Basically, how it came about is before that, before the 70s, all anal cancers, irrespective of the staging, the size, the whatever, every patient was going through an abdominal perineal resection for anal cancer. So you can imagine how dreadful it was, every patient having a stoma and that massive surgery for something that now can be treated with chemoradiation therapy. So they did their study, which was the ACT1, anal cancer treatment one. And so part of the study was to see if they give patients chemotherapy together with radiotherapy, what will be the outcome. And surprisingly, by the time they came to the end of their treatment, they realized that the tumor was gone. So this is how it ended all this APR business, where all the anal cancer patients were going through APR. So this is the gold standard treatment that we have as of now. So patients go for chemoradiation therapy for 5.5 weeks to 6 weeks, and it's a combination of chemotherapy, 5-FU, mitomycin C, and capecitabine. Those are some of the medications that they use, and it's a very it's a treatment that a lot of patients can withstand, and unless if patients react to it. But otherwise, a lot of patients can withstand that. So we've got a study that is going on, which is about to update the Nigro protocol, and this is known as the Plato study. And Plato stands for personalized anal cancer treatment outcomes. And this is being done at, I think, in Leeds, and being led by Dr. David Seberg and Professor Andrew Renahan at the Christie. It's a multi-center study. So some of the results have come out, but the trials have not actually completed yet, but we just have some of the results. So we have Act 3, Act 4, and Act 5. So the Act 4 study has been closed, and some of the results are out. So with radiation treatment, I think for the T1 and T2 tumors, they were using a dose of 45.5 to 50.5 grays in 28 fractions. But with the Act 4, I think they reduced the dose to 41.4 grays over 23 fractions. So basically, when sorry, just some interference there. So when treatment is given as a lesser dose and also less fractions, then which means it's got a better outcome for the patient, because the side effects will also be less. So I think these are the aims of these studies, so that at least we improve the quality of life for patients at the end of treatment. All right. So while we're looking at the treatment for anal cancer, can you give 3 scenarios where radical APE may be considered instead of chemoradiation therapy as the primary treatment for anal cancer? So basically what we are saying is there any treatment that's any scenario of anal cancer that can be sent straight for surgery without going through chemoradiation therapy?
Can you see the answers, Noreen, coming up in the chat box?
Yeah, they've had radiotherapy before, patient choice, previous radiotherapy, recurrence, in the absence of metastasis and no lymph node involvement, patient decision, recurrence, large locally advanced or no response, patient choice, previous radiotherapy. Yes, I can see those answers. Thank you very much. I think all those answers, they've covered most of the situations or scenarios whereby patients may be taken straight for surgery without really going for chemoradiation therapy. Very small tumors outside the perianus, they can just go for excisions, wide excisions. And then we do have previous pelvic radiotherapy and curative radiotherapy that has been given before, so patient will not have repeated chemoradiation therapy in the pelvis. So they can only have chemoradiation therapy in the pelvis once and not twice. Okay, a histology of adenocarcinoma or adenosquamous carcinoma. I don't know if a lot of you have come across that, but adenocarcinomas of the anus, they respond very poorly to chemoradiation therapy for the anus. So sometimes when a patient is diagnosed adenocarcinoma of the anus, they go straight for APR because even if you take them for CRT, then they don't respond better. We recently had a scenario where we had a patient who was diagnosed adenocarcinoma of the anus. So they were discussed in both MDTs, our colorectal MDT and the anal MDT. So after the back and forth, they were eventually sent off to go to the colorectal MDT, where they went through chemotherapy for adenocarcinoma, for a rectal adenocarcinoma. And then after that treatment, when the oncologist did some scans, realized that it was it was a squamous cell carcinoma. So it was very confusing. But anyway, patient had to go through another treatment, another 6 weeks of chemoradiation therapy for anal cancer. So we're just waiting to see the outcome of that. So that's one other area, one other scenario. And then what about transplant patients? Some transplant patients, if the oncologist think that they are not going to pull through chemoradiation therapy, then they would not let them go through that. And sometimes also they are worried that they may damage the pelvic kidney. So they would not really recommend patients with transplants to go through chemoradiation therapy. So they would just go for surgery. And then an exceptional is patients who refuse to go for chemoradiation therapy. So yeah, thank you very much, everyone, for those answers. That's brilliant. Okay, let's proceed. Okay, so that's a treatment algorithm for localized anal cancer. I got this from the ESMO guidelines. So it just gives us a picture of how anal treatments will go. So with localized anal cancer, if it's anal margin cancers, T1 NOMO, they go for local excision. And if if there's a clearance of more than 1 millimeter, then they go for follow-up. If there is a histological clearance of less than 1 millimeter, they go back, they go to a low dose CRT, and then they go for follow-up. And then if it's a stage 2 to 3 anal margin and a stage 1 to 3 anal canal, patients will go straight to anal cancer, to chemoradiation therapy. So with anal margin tumors, the reason why they don't want to push it and do wide excisions is because if they are big tumors, they will damage the anal sphincters. And then instead of doing good to the patient, they are actually causing more damage because patient will have a lot of complications thereafter. And then we have, for these patients, if there's a complete response, they go to follow up. And if there is a residual tumor, then they go for salvage surgery, depending on what has been found. Some will go for APR and some will go for exonterative surgery. And within follow up, if there's a local relapse, then they go for surgery again. If there's a distant relapse and metastatic disease, then sometimes they just get managed as metastatic disease, or maybe go for further chemotherapy or exonterative surgery, or anything that can be done as per assessment by the oncologist. I know there's somebody who asked a question later on. Hopefully we'll find it and then I'll just answer at the end. So risk factors for poor outcomes, everything is worsened by an increased T stage. If it's a T4 tumor, T3, T4 tumor, or N1B, N1A, N1C, depending on the nodes that have been affected, it kind of, the outcome sometimes is not very good. So like I said, tumor stage, nodal status, and also the histological differentiation. You find that poorly differentiated anal carcinomas, sometimes they don't do well. These are the cancers that sometimes tend to come back at 6 months. Histological differentiation and male sex, 5-year survival after salvage. Okay, I'm just going to go through the acute side effects very quickly. So occasionally radiotherapy complications can lead to treatment interruption. So we've got skin toxicities. Patients suffer quite a lot of skin soreness, inflammation, irritation, red, darker, dry, flaky skin. We've got gastrointestinal complications, diarrhea, nausea, genital. There's loss of pubic hair. Rarely do they lose their hair in the head, but pubic hair goes. And then there's a lot of pain, fatigue, bladder irritation, causing frequency agency, hematuria, incontinence, and burning sensation. Also, in the those side effects, we do have hematological toxicities as well, where patients will suffer leukopenias and thrombocytopenias. Okay. Maybe I'll pass through this question because we are slightly behind time. And then if we have time at the end, we can always come back. Beth, do you agree? Some of the possible long-term side effects, and I mean, those that affect patients' quality of life. We have patients, say, 6 weeks post-chemo radiation therapy, and sometimes they even go up to 3 years, 5 years. Patients will complain of frequent or loose stools, fecal incontinence, where they will most probably need help from us with just can't wait card. Bladder changes, like I said, sexual function. A lot of patients that have gone through chemoradiation therapy suffer chronic vaginal dryness and stenosis, vaginal fibrosis, chronic dyspareunia, reduced sensation affecting receptive anal sex, painful receptive anal sex. Same applies to women as well. There's reduced sensation. So their sexual life is really lost. Some can have chronic proctitis where they are bleeding from the anus. Fatigue can affect some patients for long. Anal pain and discomfort, early menopause, infertility, lymphedema, low level B12, leading to loss of numbness, leading to numbness and weakness sometimes. Right. So we are saying, is anal cancer preventable? Comparing to what has happened with cervical cancers, anal cancer, we think it is preventable. Just like cervical cancers that has had 90% success. Obviously, it's different anatomical sites, but I'm sure we can get there by managing the AIN precursor stage of anal cancer. And with that diagram, I was just showing that anal cancer and cervical disease is actually comparing. Anal cancer is on the rise. These are the triangles. It's going up. And cervical cancer is coming down. Some of the HPV-related anal cancers remain the same there. So we really need to focus on anal cancer because it is on the rise. I'm not going to touch much on that and management of AIN. And the current research study that has been done is the anchor study, which is called Anal Cancer HCO Outcomes Research. So this is a research study that has proven that there could be a 57% reduction in progression to anal cancer if the pre-cancerous stage of anal cancer is treated. So it's an American study where they randomized 4,446 patients in a treatment arm and a non-treatment arm. And in the monitoring arm, they found 21 cancers. And in the treatment arm, they found 9 cancers. So proving that it is possible that we can prevent anal cancer through treating high-grade intraepithelial neoplasia lesions. This one is the same diagram that's showing us that it is possible for us to do that. And last but not least, it's no longer okay to ignore AIN, which is the pre-cancer stage of anal cancer, because we can treat it and prevent patients from developing anal cancer. Why the interest? Anal cancer the incidence of anal cancer is on the rise. There's a rising population of the well immunosuppressed, and cervical cancer is sorted, and we're looking at new horizons. And what next? We are now looking at screening and also looking at vaccinations, which may eliminate most of the lower anogenital cancers. The HPV vaccine, patients can be vaccinated with HPV vaccine, and the most good uptake is for the 11 and 12-year-olds, and it's open to up to age 26 in the NHS, and patients can negotiate vaccinations with their GPs up to the age of 45 in sexual health clinics. So there is a Gardasil 9, which contains 9 different strains of the vaccine, and it's a very safe vaccine which can be given to patients. And if one has contracted HPV already, the uptake is not that great because they are already exposed to HPV. But if you've been affected by one strain of HPV, you can still be protected against the other strains that are in the vaccine. And that's it, really. Thank you. Sorry, I went beyond time.
Do not apologise, Noreen. That was great. Thank you so much. We've got lots of questions, so if it's okay, if you're all right for time, I'll just take a couple of minutes for us to just answer some of those, if that's all right.
Sure.
So we had a couple sent ahead. One you answered definitely during the talk about immunotherapy. There was another one about is there any guidance on using vaginal dilators during or after treatment?
Use of vaginal dilators during treatment, you find that vaginal dilators are recommended towards the end of treatment, 4 to 6 weeks towards treatment. But this is the time when patients are experiencing a lot of pain as well. So they are not able to use their vaginal dilators due to pain. But during treatment, they can use tampons because to prevent fibrosis and to prevent the vaginal stenosis. I think in the radiotherapy departments, they can use specific tampons that are inserted into the vagina so that at least you minimize the radiation therapy that is going into the vagina, because the vagina is in the field of radiotherapy.
Yeah.
And after treatment, they can start using their dilators 4 to 6 weeks after, and they can do that twice a week or as per when they can manage to do that. And it's very important that patients use vaginal dilators.
Thank you. That's great. So the tampons are for prevention, and then the dilators are afterwards to manage the
The
stenosis.
tampons are just to control. I don't know if it's done in every oncology department, but they are just to control the amount of radiation that is affecting, the vaginal walls that are in the field of radiation.
Okay, thank you. Another question here from Rona about what's the most effective management for rectal spasm?
For rectal spasm, it's very, very difficult because we've had patients who came in with anal pain and rectal spasms. And to tell you the truth, I don't know what sort of best management for rectal spasms. I've not really come across a patient with spasms but pain. And besides taking their analgesia, there's nothing
Yeah,
else that I've seen being
it's a
put
tricky
through.
one, isn't it?
It's a tricky
I
one,
guess
yes.
analgesia, and if it was really problematic, thinking
Yeah,
about stoma formation and if that would help, I guess, but
exactly. We
whether
had
it
one
would or not, I don't
patient
know.
with severe rectal pain. They ended up having a stoma. And by the time they started receiving treatment for HSIL, like laser ablation inside the anus, amazingly, the pain stopped. We don't know how it happened, but the patient feels a lot better now.
Yeah, okay, that's good. Thank you. Then another couple about vaccines. If you've had the HPV, I think you talked about this, but just to recap, if you've had the HPV vaccine, could you still get HPV related anal cancer if you're immunocompromised? Good question.
Sorry, come up with the question again.
So, right, so there are two questions about this really. So, does the HPV vaccine protect if you have it before you become sexually active? So that's the first part, and then does it protect if you're immunocompromised?
It does. We do recommend even those patients that are HIV positive or any other patient who is immunocompromised to take on the vaccine, because if you are affected by one type of strain, then you will be able to be protected against the other ones. But truthfully, or what literature says, HPV vaccine is best given before you are exposed to HPV. It works better that way.
Yeah,
Remember, there are hundreds of types of HPV strains, so you can't really say you are protected from all of them by the vaccine.
yeah. Okay,
Because
thank
what's
you.
in the vaccine is the high risk types that are highly likely to give you some cancers like cervical, oropharyngeal, anal, vulvar, vaginal cancers.
Okay. Another question here. Does DARE need explicit training like DRE, and therefore can it only be carried out by someone who's been trained?
Well, I did on-job training. I won't say I really went for a course, but through reading and through experience, that's how I got to do DAREs. But definitely you need to know what you're doing when you go inside the anus, because you need to know what you're looking for and how it feels. So you need to be guided by someone. One of the consultants or one of the doctors can guide you, can teach you, and then together with literature on the International Anal Neoplasia Society, there's a good I think it's not a study, but it's an account of how to do digital anal rectal examination that has been put there. So you can learn a lot by reading as well. But I think hands-on is the best. And
Yeah,
doing
definitely.
loads and loads of them, you end up you being good at it.
Yeah, I would agree. Find a friendly consultant
Yeah,
or experienced nurse, and that's
yeah,
the best way to learn, isn't it?
to
And then
learn. Yeah, true.
yeah. Um, a couple more. I promise everyone we'll finish by 1:15. Thank you to those of you that can stay, and we will. So is that okay for you, Noreen? Is that all
Yeah,
right?
yeah, it's okay for
Um,
me.
there's a question here just about survival rates, and you did go over some more recent studies at the end, just saying the survival rate cited was 2010. Is there anything more up to date as treatments have advanced?
I haven't seen anything up to date, but I was looking at some of the survival rates from a paper that I was reading, but I know it's a recent one because anal cancer screening it has been done recently, and this is from an Australian professor. So what he said is for cancers that are less than 2 centimeters, there's an 80% 5 year survival. For tumors that are above 2 centimeters, there's about 45 to 65% 5 year survival. And metastatic cancers, there's only about 20% 5 year survival.
So it's a
So
huge difference, isn't it?
it's a huge difference, but this is just from that paper. I wouldn't know exactly what's going
Yeah.
on. Yeah.
But it really emphasizes the importance of the vaccination programs and screening
And
and awareness
screening.
in health professionals because it's difficult.
Yes.
It's difficult to
And
diagnose, isn't it?
yeah,
I think it's easy to be concerned about missing anal cancers when you're in general colorectal
exactly.
practice.
And the importance of finding very early cancers, which will lead to at least 80% survival rate in when they are treated.
Yeah. Thank you. There's a question here that I want to get to about follow-up. How do you provide surveillance for AIN? Do you do EUAs or do you see them in clinic and how often, please?
For HRAs, we see them in clinic and we see them every 6 months where we do a digital rectal examination, we do HRA, we perform biopsies, and if patients can't withstand HRA in clinic, they are sent off to theaters where they have their examination under anesthetic.
Okay. So, and for anal cancer surveillance, do you have a protocol that
You
you
mean
follow?
for just for examinations? Yeah,
Or yeah,
for everything. Okay, for anal cancer, our protocol is we see all anal cancer patients, irrespective of the stage, irrespective of where the cancer was, whether it's an excision of a perianal cancer. We see them every 4 months for HRA in clinic, and that is for 2 years. And then thereafter, we see them every year. And sorry, we increase it to about 6 months and then to a year, depending on how they are presenting. And for radiological examination, our patients go through 6 monthly MRI scans for 36 months and yearly CT scans for 36 months. And then any other patient where we think there's a recurrence or we are worrying about anything, then it's an ad hoc MRI or CT scan.
fantastic. Thank you so much. I think we're going to run out of time. There's another question about follow-up for patients that have had chemorads and subsequent salvage surgery about follow-up advised.
Right. If they've had salvage surgery and they don't have an anus anymore, we don't see them in our department because we have actually nothing to do. So, but I've worked with a consultant nurse in one of the hospitals, and our patients the patient that had had exaggerative surgery or salvage surgery, they were just going through CT scans and management of other problems and quite a lot of support
Yeah.
from the nursing teams.
Thank you. And I promise this is the final question. Is the chemo part of is the chemo oral or IV? Is the chemo that's part of the
It can
treatment?
there's IV and there's also oral. Capecitabine is
Yeah.
usually oral, and they can take it throughout the 6 weeks or 5.5 weeks. And the 5FU and the mitomycin C, I think it's at the beginning and then towards the end of the treatment.
Okay, that's great. Well, I think we're dead on 1:15. So if we didn't get to your question, I'm sorry. I think we answered almost everything, and that was fantastic, Noreen. You are so knowledgeable on this topic, and we've all learned a real lot this afternoon. So thank you so much.
Oh, thank you very much to everyone. Hopefully, you've picked one or two from this presentation. And yeah. I hope to learn from all these guys. I know they're all very experienced colorectal nurses, so I hope to learn from them as well.
Thank you, Noreen.
Thank
Thank
you
you,
very
everybody,
much.
for watching this afternoon, and please do watch back.